George Mensa, a co-founder of the National Forum and the director of the National Heart, Lung, and Blood Institute's Center for Translation Research and Implementation Science, recently posted that uncontrolled hypertension isn't a medical mystery, it's a systems failure we know how to fix. He added that countries like Bangladesh, the Philippines, and the Republic of Korea have proven that rapid progress is possible. The tools exist, the evidence is there. What's missing is urgency. I could not have framed our purpose in today's convening any better than Dr. Mensa just did. It is to catch up on the latest tools, review the evidence, and most importantly, raise the urgency to prevent and control hypertension. We'll now begin session one, leveraging innovation using AI, EHR, standardized protocols, and new treatments to improve hypertension control. As we've discussed, hypertension remains one of the most pervasive and preventable drivers of heart disease, stroke, kidney disease, and cognitive decline. Yet despite the tools we have today, control rates remain far below where they should be. This session is focused on how we change that, how we move from fragmented one-off efforts to scalable system-wide solutions that truly improve outcomes. We're fortunate to be joined by three leaders who are advancing innovation in very practical, impactful ways. For time's sake, I will be giving extremely abbreviated introductions to our esteemed speakers, so please refer to the program book that's online for their biographical sketches. First, we're going to hear from Dr. Paul Leeson, professor of cardiovascular medicine at the University of Oxford, who will explore how artificial intelligence and data-driven tools can inform how we identify and manage hypertension, helping us find patients earlier and intervene more effectively. Next, Dr. Dan Lackland, professor of epidemiology and neurology at the Medical University of South Carolina, will discuss the role of electronic health record integration and clinical decision support in closing care gaps, bringing hypertension management into everyday workflows across care settings. Then, Dr. Madeleo Ganiyi, professor of medicine and master physician at the Emory University School of Medicine Division of Cardiology, will share insights on standardized treatment protocols and emerging therapies that are improving outcomes at scale. After the presentations, we'll have about 15 minutes of discussion and questions and answers. So please submit questions at any time using the Q&A button on your screen so we can incorporate your questions into the conversation. With that, let's get started with Dr. Leeson.
Lovely. Thank you very much. Let me start by saying I'm very grateful for the opportunity to come and talk at this National Forum, which clearly has a huge significance for delivering improved hypertension care across the US and as an exemplar for the world. To give you a bit of a background, I'm based in Oxford in the UK and have had interest in hypertension for many years, running the hypertension service here in Oxford for the Oxfordshire region. And we see many patients across the age range with different levels of hypertension, needing different levels of hypertension care. In parallel with that, I have a research program which has been particularly interested in how we apply AI and AI methodologies to different aspects of cardiovascular prevention, particularly with a focus around imaging, because imaging is very widely available in lots of the centers we work within and provides a very quick and easy way of getting to understand what's going on with the cardiovascular system of an image. I see a future of hypertension and AI in which we can bring some of these things together, whereby we can use advanced imaging to better understand heart disease underlying hypertension or being driven by hypertension, but also find better ways of managing and treating hypertension and also discovering new therapies for it. I think we're all very aware now of AI being part of our everyday lives. And in some ways, the advances in AI are not yet fully making it through into medical practice. And so there is a real opportunity here for us to guide and drive how we use AI as a tool within our medical care. Why AI is so attractive right now is because of the changes in availability of large sets of data on patients. And I'm sure we're going to hear about electronic health records as a source of information. We also have new imaging-derived measures of disease practice. And we also have very powerful computational approaches we can apply to these large data sets, which allow us to look at it in different ways. The concept of automating how we care for patients and using machines to better understand how we care for patients is not new. It's been around for decades, but we're at a really pivotal moment where we can start to really plug into this to change how we manage hypertension. I think one of the key things which I want to talk about, there are three areas I'm going to focus on. First of all is the opportunities of AI in identification, the opportunities of AI in how we manage and treat blood pressure, and then the opportunities around personalization. And personalization is really one of those interesting aspects of hypertension care. We have at the moment thresholds which are hugely important for driving understanding of blood pressure and understanding how we achieve a good outcome for patients. But each patient knows themselves that actually the blood pressure alone is not what makes them understand their disease process. There are things which are going on underneath their blood pressure, including changes in organ function, organ structure, and in how they're feeling, which actually differentiates one patient from another patient with exactly the same blood pressure. And also the blood pressure patterns and how blood pressure changes during the day, how it changes for the individual, whether it's systolic or diastolic, also varies by patient. And the beauty of AI will be to allow us to better personalize how we approach it. So let me talk about identification. One of the opportunities of AI is new ways of identifying the group of patients who we know are not being treated appropriately for their hypertension or are not even aware of their blood pressure problems. The kind of opportunities that exist within this space actually come through some of these aspects we've been talking about around how people are accessing and using AI all the time to get information from websites and others. With proper approaches to how we provide that data and provide that information, we can provide very effective tools for patients to be able to interrogate and start to understand that they may have a blood pressure issue. Or a patient might be attending for another medical test, such as an eye test or a test on their blood test. And from this information, we now know, using large data and AI, that we can pick out those patients who are likely to have hypertension without even needing to know what their blood pressure is at the time they get that test. By flagging this to a patient, they can then go themselves to find out what their blood pressure is, and you potentially start to uncover large tracts of the population who previously were not getting their blood pressure checked. But because of their interaction with health services in different ways, the AI has allowed to identify those patients. When we think about treatment and how you manage blood pressure, very often we work with complex systems of different guidelines for how we might give different medications, and we have to make decisions based on blood pressure levels. Again, by combining large information on how patients are responding to different treatments and different medications, and use guidelines in an automated way that guidelines become adaptable by machine learning processes, you can start to provide AI-given guided decision-making to patients in terms of what medications they choose, or indeed what medications or dosings they might want to use, which can accelerate treatment. And finally, the personalization. As I was saying, each patient has very different patterns of blood pressure. And now we know, and this is some work we've been doing, particularly in Oxford, with very large data sets, which can combine imaging, genomics, epigenomics, and other factors, we can actually start to now piece together a much better understanding of the different types of hypertension we are seeing, and actually grouping people into different patterns, different trajectories, who potentially have different outcomes in terms of whether they're likely to have a heart or a stroke. And really, this is a new phase which we very much hope will be coming in, whereby we can start to choose our medications and choose our advice we can give to patients in a much more personalized way. So I'm going to wrap it up. That's been a very quick overview, and we're looking forward to answering questions on this as well. But I think AI has huge potential now in terms of how we look after patients and prove better outcomes. These AI needs to be validated, but I think in terms of identifying patients, in terms of better treating patients, and providing more personalization, we are now very well placed to deliver this AI revolution.
Thank you, Dr. Leeson. We'll now move on to Dr. Lackland.
Very good. Thank you, John. It's wonderful to be here, and this whole piece. And I thank the National Forum for this wonderful opportunity. And certainly, it's a pleasure to follow Dr. Leeson as he was discussing. So we have some slides. This is kind of what we'll talk about, is actually to discuss a little bit what Dr. Leeson was bringing in, and also looking at the electronic health record. The way we look at this, I think very nicely, as Dr. Leeson said, we use this and employ these mechanisms to improve hypertension control and management. And that's an important piece. So it's bringing in here, how can we make this more efficient? So if we take the electronic health record, if we take the clinical decision support that was described, it reduces the management gaps and provides a real life team and real life evidence-based type of approach that we're able to see automating and centralizing the patient data, just as Dr. Leeson was describing. It also is used in the management by synthesizing this data across the healthcare continuum, just as we were discussing, using these different techniques to basically assist the clinician to identify and address and control and close these gaps that we see in hypertension management. How we do that, some little bit specifics in this area of what can be done. Well, one, this new mechanism can provide alerts and reminders for the different patients, keeping people up with an up-to-date part, not what was seen maybe a year ago or whatever, bringing it up to date, opportunities for that. It improves control by facilitating this real-time data monitoring, automating these alerts that you can provide, and also enabling this patient registry, which also gives you kind of a comparison between how the different patients are doing on different aspects, and give you a kind of a one-shop quick feeling for that and identification. The systems also streamline the flow for the providers, allowing better identification, tracking, and management of patients, often through targeted alerts, ordering different sets, and patient portals. It also, very importantly, provides something that's essential for hypertension management, and that's standardized care, doing things in a similar type of manner. This provides, for example, evidence-based guidelines, whichever that protocol that you're using. These systems will allow you to put that in there and make your patients and management following these standardized guidelines. It reduces medication errors because it's providing you at a very quick manner, allowing the computer to generate what you need to know in the way that we're looking at medications and treatment. And very importantly, it identifies white coat hypertension and masked hypertension, things that are somewhat complex in identifying in hypertension world. Does this for you. This enhanced information exchange, it provides a comprehensive data access. Just as Dr. Leeson was saying, it provides all of these pieces together and puts it in more of a holistic review of the patient's history, eliminating fragmented care where you've got diagnosis over in this category, blood pressure measurements, over here are the lab measurements, over here are some issues with the pharmacy, different types of treatment, all kind of fragmented in one sense that we see now. This allows us to put everything together, and employing things like AI, it gives you kind of that dashboard where it would take hours before, now it takes seconds to get you that type of information. A very important key part is it also brings in improved communication and shared data ensures across all members of the team now, as we go with team-based care, improving that communication. And here are the kind of key roles to kind of spell it out in one additional type of sense. Looking at closing that gap, looking at the first part, the clinical decision support. This provides a timely patient-specific information to the providers, provides alerts for high blood pressure, and also recommendations on the treatment and the actual management. Again, lowering that concern about clinical inertia. The EHR, the integration automation, it provides the data that's in that electronic health record and puts it there so that you can also include things like blood pressure monitoring from out of clinic measurements from all over the different clinics, and allows the data to flow in a very nice way. Also, it provides you a patient registry. Now, from what I do, population health, this provides that type of information. But the EHR system can also provide you a registry of all of your patients with hypertension, kind of giving you a comparison. How are you doing? how are the patients doing? It allows for improved patient monitoring, like we've been discussing, and this other piece. The other piece, the last one, is such an important point. It brings in evidence-based care alignment. It brings in the EHR, bringing that in and bringing the care in that fashion. Thank you. It's great to be here.
Thank you very much, Dr. Lackland. Now we'll move on to Dr. Ogani.
Thank you for the opportunity to be here. I'm supposed to be talking about standardized treatments, protocols, and emerging treatments of hypertension that improve outcomes at scale. So we all know why we're here. Why are we focusing on high blood pressure? Why is the National Forum focusing on high blood pressure? We know it's the most prevalent and modifiable risk factor for development, not only of cardiovascular disease, but of stroke, of dementia, and all-cause mortality. We also know that it is a significant contributor to the cardiovascular kidney metabolic disease. But if you don't listen to anything I say today, what I want you to take home and what has been emphasized today is that the overarching blood pressure treatment goal is less than 130/80 for all adults. But with the caveat that there are additional considerations for special populations like those who are in institutionalized care, have limited predicted lifespan, or are pregnant. So again, blood pressure goal. Systolic blood pressure less than 130, ideally, if we can, less than 120, because we know that the lower, the better. And a diastolic blood pressure less than 1. In the guidelines, a class 1 indication. In patients who have confirmed hypertension, using the PREVENT calculator, we say a systolic blood pressure less than 130, ideally less than 120 millimeters of mercury, with a diastolic blood pressure less than 80. So moving right along, because we have a lot to cover in 5 minutes. These are just some examples of standardized protocol and implementation strategies. We know that stepwise algorithm, as exampled by the WHO HEARTS, help to titrate medications. Simple linear decision trees, it reduces a standardized treatment and reduces provider variability. Examples of standardized protocols, the Kaiser Permanente model, have standardized BP measurements as well as treatment algorithms. They also prioritize team-based care with performance reporting, and that has led to them achieving a whopping 90% blood pressure control. And when you think about the US, where less than 1 in 5 people have blood pressure control, these are some examples of implementation strategies or standardized protocols that we should think about scaling up. You've heard today, just in the first session, about team-based care, using our pharmacists, medical assistants, nurses, a multidisciplinary team, which indeed was one of the top 10 highlights of the new blood pressure guidelines. We know that pharmacy-led blood pressure management programs are successful. We know that engaging our nurses, our medical assistants, using community health workers, team-based care is an example of a successful implementation strategy. And remote blood pressure monitoring, we know that self-measured blood pressure monitoring, not only that, but with follow-up, either virtual follow-up, digital follow-up, but taking actionable steps on that. These are examples of how we can implement to move towards the goal of getting blood pressure controlled. Now, moving along, we're just going to highlight novel therapies. There are lots. This is an exciting time for the treatment of hypertension. There are a lot of clinical trials going on. There are a lot of new drugs that are available, and a lot of trials going on to demonstrate, can we control blood pressure? Also in the guideline, we talk about renal denervation. But in the guideline, we say that all patients being considered for renal denervation should be evaluated by a multidisciplinary team with expertise in resistant hypertension. And when we contemplate renal denervation, we need to have that shared decision-making process initiated to ensure that patients choose a therapy that meets their expectations. So I always say that I am solution focused. We can identify barriers to implementation, but can we come away with solutions? So this is just a few, and I will look to this crowd to help us generate solutions or to offer some barriers that I haven't listed here. There is therapeutic inertia, and you've heard from the previous speakers, automated EHR alerts, implementing protocol-based titration are some of the things that we can do to overcome therapeutic inertia. We talk about medication non-adherence, combination pills, mobile health reminders. Dr. Ferdinand, who's one of my mentors and a leader in this space, did a trial where they were saying text to BP. They were texting patients reminders. Have you taken your medication today? Those are examples of projects that we can upscale to overcome the problem of medication non-adherence. You've heard the word social determinants of health. Community health workers are well skilled to address the adverse determinants of health that lead to inadequate blood pressure control. Screening, embedding this in the EHR is also another process. Fragmented care. Can we have registries? Can we share care plans? And of course, addressing the issue of care. So as a roundup, these are my take-home messages. We have the evidence, and we know the guidelines and the evidence align. So it's time for systems, healthcare system, governmental system, all systems to act now to achieve blood pressure control. With standardized protocols and team care, so we can achieve blood pressure control, we have the evidence. We need to implement evidence-based blood pressure management protocols. And in all we do, it is important to center this in equity. And finally, we must act now to control hypertension because the status quo of uncontrolled hypertension is no longer acceptable. Thank you for your time.
Well, I'm sure that Dr. Mensah is smiling right now, Dr. Ogani, because you tied your comments right into his call for a heightened sense of urgency. Certainly something that we share. We're now going to move into our discussion and Q&A period. This is an opportunity to connect the dots across what we've heard, AI and data-driven tools, EHR integration and clinical decision support, and standardized protocols and emerging treatments, and to explore how these innovations can work together to drive meaningful, scalable improvements in hypertension control. We've already received a couple of excellent questions, and we welcome more. So please continue to submit your questions using the Q&A button on your screen, and we'll do our best to get to as many of the questions as time allows. So let's begin with a question for Dr. Leeson. Paul, is AI ready for clinical use to manage blood pressure?
Yeah, I think that's a brilliant question in terms of, I think, and we address this in two ways. One is AI, interesting, is being used for clinical use by patients, by using techniques which are available on the internet already. So I think that's something we have to be aware of when we're looking after patients, is that they are getting some information using AI technologies. And so that's something we need to be aware of and wary of as well. I think at the moment we have some really good tools emerging about how you can give good advice using AI technologies, and they need to be got better. They need to be trialed and brought into practice quickly, because what we really need is those techniques using AI which are providing the best quality information for patients, and that's kind of a piece of work which is moving rapidly. There are AI tools are available in practice in different areas, particularly within within imaging. So if you are wanting to do some further evaluation of end organ damage or things in patients with hypertension, often those will already be AI enhanced, the techniques we have. So it is coming through in different spaces. And I would expect a lot more work to be done in that information space and the guidance space relatively rapidly.
Thanks. And I've seen claims that AI can massively improve the accuracy of diagnoses, AI integration in reading imaging. Is that accurate?
Yeah, and I think the interesting piece around that is that the blood pressure leaves signals of its presence across lots of different parts of the human body. So you're looking at the retina, or looking at the heart, or looking at other blood profiles. So there are signals of hypertension being an issue that can be picked up automatically using AI systems, which can flag this to the patient or the doctor to be investigated further. And I think that sort of additional value that you're getting from the application of AI is something that will provide benefit for us as we manage hypertension, and importantly, identify patients at risk who currently don't realize they're at risk.
Yeah, yeah. Well, thank you, Dr. Leeson. Dan Lackland, we have a question for you, which is,
Yes.
do you need a sophisticated EHR to properly manage high blood pressure?
It's a brilliant question. It is a brilliant question from the global aspects, from the national aspects, from the regional aspects, from the local aspects. The answer is clearly no, capital N, capital O. You want to implement your strategies. So blood pressure, a standard protocol, blood pressure measurement protocol with validated devices, the team-based approach, things that we've heard about very, very nicely about implementing a blood pressure control program. Yes, you can implement that without AI, without a sophisticated electronic health record. And sometimes the complexities and the resources are just not available. So we say, let's get in with the components of hypertension control and management, implement that, and then let's work on these other great resources that we've discussed that will help facilitate that management, but implement that as soon as possible, because half the population needs this approach.
All right. Thank you. And Dr. Ogani, particularly your closing comments reminded me that I often think when we're trying to increase the sense of urgency to detect and manage high blood pressure, to prevent hypertension and control it, that really all we need to do is have Model A Ogani appear everywhere and say what you said, because how can you not hear your message and feel that sense of urgency? But we can't. We can't do that, unfortunately, because you have patients to see at Emory, people who are depending on you. So another phrase that you didn't use today, but you have at other times, is that you've talked about the lethality of uncontrolled hypertension. And that's always struck me as not just a pithy, but a very powerful statement. So I'm wondering, can we persuade the public and clinicians, and perhaps most importantly, healthcare system decision makers, that this lethal condition demands action now?
Thank you, John, for that question. I think it's a three-way approach. But I think from the patient perspective, one thing I've found helpful is the power of storytelling. So when you think about tobacco control and the ads you see on TV, it's very compelling, right? You wouldn't want to pick up a cigarette. But if you have a patient, you involve a patient or a patient whose family has been affected by the complications of hypertension, kidney disease, stroke, heart attack. So I think that we don't do a good job in the space of hypertension to employ that powerful tool of storytelling of the patient with hypertension, telling their journey, all the complications, all the difficulties they have with managing blood pressure. I think that with policymakers, I've seen that happen as well. I attended a hearing where Medicare was considering whether to cover blood pressure monitor, and I think you were on that call as well. A lot of organizations came, clinicians came, they talked about why this needed to be controlled. But at the end of it, a clinician invited her patient, and the patient talked about actionable steps. She talked about how she measures her blood pressure, sends it to her doctor, and her doctor makes recommendations. And at the end of it, they summarized and said, bring more patient stories. So challenge us to think outside the box and consider using the impact, the power of storytelling, the power of the effects of uncontrolled hypertension, the early complications, the groups that are disproportionately affected, and I think that may be a way to change the narrative and let people know that although we call it the silent killer, it is killing people. Thank you.
Yes. And Madeleine, I'm so glad that you just mentioned storytelling, because I think so many of us are accustomed to making decisions based on objective data, and we often overlook the importance of storytelling and how powerful stories can be in persuasion. So I'm glad you mentioned that. We have an important question from Christina Danhausen. She asked, in many rural areas, health systems are struggling to even have modern EHRs. How can we create equity in the US with regards to having the technology needed to be working in AI space and the EHR clinical integration space? Can we answer that in about 1 minute?
Okay. John, I might go first. I think it was very, very similar to what we've had. So brilliant question. And again, from the World Hypertension League standpoint, this is the major question. And so we have great resources and great evidence-based materials, but you don't have the resources to pay for it and to put and to turn around and do an implementation. And that can be all aspects of it. What we've done with the World Hypertension League is our recommendation is implement what you're able to implement now. Recognize blood pressure as essential to control, implement what parts you're there, and then let us work with you to gain these other resources and to implement them as they go. But the first piece is taking that first step. Identifying blood pressure is a top priority for you and implementing that system. So marvelous question.
All right. Thank you, Dr. Lackland. And Dr. Leeson, I'm going to throw the final question across the pond to you. Selena Gore, the CEO of Women Heart, asks, as we know, women are often underdiagnosed or misdiagnosed, undertreated, and certainly under control. What can patient organizations do to ensure that the benefits of AI are realized for those that the system currently leaves behind?
I think it's a brilliant question. And this is kind of one of the areas we are very keen to push, this concept of how we manage cardiovascular disease for women, because at the moment we have very, very standardized approaches across the population. And there are some particular areas which we are just ignoring to a large extent. I think in women in particular, there's some real moments particularly in early life, where we have great opportunities for prevention. And what springs to mind, obviously, is a hypertensive pregnancy as a red flag warning sign in women very early on that they have a hypertensive problem. And we know these women are at particularly increased risk. So we're particularly interested in how you drive that messaging at that touch point with healthcare, where you can start to implement things which are going to really make a difference for these women, which may prevent a lot of those later life complications right at the root. And that's a unique opportunity in women that we don't necessarily have in men, that we have an opportunity to do a great piece of work around. And I think AI is relevant here in terms of, struck by those other two comments, in terms of how you pick up early disease and tell a story where although the blood pressure number is hugely important, what is going on underneath in terms of early development of disease is really important to capture. And so the patients can understand that it's not just about a number, it's about what other disease patterns are emerging. And again, in women as well, understanding how the heart might be changing, how there might be very female-specific risks and diseases which are developing relative to their blood pressure, starts to tell that story as well.
Thank you, Paul. Very, very important question. We appreciate the thoughtful answer. Dan Lackland, I think you would like to say a word about World Hypertension Day. We can give you a moment on that, and then we'll close out this terrific session.
It was a terrific session. I'm honored to be with the two panelists a great deal. May 17th is a day for everyone, and kind of fitting in the parts like this. Do we have an EHR? Do we have AI? Do we have implementation of the difficulties? Regardless, May 17th is for all of us, World Hypertension Day, recognizing it there. And so we encourage everyone to kind of participate and be a part of it with the resources and the passion that you have, and implement that, but recognize, very important, May 17th, World Hypertension Day. Thank you.
Thank you, Dan. And thank you to audience members for the thoughtful questions, and to Madeleine Ogani, to Paul Leeson and Dan Lackland for a rich and practical discussion. What we've heard in this session is clear. Innovation is not just about new tools, it's about applying them in ways that are integrated, scalable, and focused on improving outcomes. So from AI and data-driven insights to EHR-enabled decision support to, very importantly, as Dr. Ogani said, standardized protocols and emerging treatments, we have real opportunities in front of us to move the needle on hypertension control. The challenge now is ensuring these innovations are implemented consistently and that they reach the patients and communities who need them most.